Welcome to the first of 4 webinars that we're doing concerning updates on the PPACA healthcare reform laws. This first presentation is titled PPACA, A Continuing Evolution. And I should note, just for the record, that this material and the material of the next 3 courses was basically developed around mid-September 2012. I make that note because it's difficult to know when someone may be looking at this webinar at a later date. We suspect by the 1st of January 2013 that there'll be an enormous amount of continual regulatory explanations coming out that may change many of the details that you're reading in this webinar, and we'd advise you to stay in touch with your Ward & Brown sales representative to make certain that you're available to any additional webinars or presentations that we might do. To get ourselves started, what we probably have to understand is that PPACA has been a continuing evolution from the beginning. Ward & Brown did a series of seminars in the spring of 2011, and these are the latest updates since that program about 1.5 years ago. The number one thing that's changed during that period of time is rather obviously the Supreme Court. The Supreme Court was expected to rule on whether the PPACA law was a constitutionally mandated law or not, and surprising to everyone, the Supreme Court ended up making their decision on taxation issues. In general terms, we're going to talk about this a little bit more in a minute. The Commerce Clause, upon which the mandate argument was made, was in fact rejected. It really didn't make any difference. The Commerce Clause was rejected in the end. We'll explain that in a second. Because the Supreme Court still held up the act. What the Supreme Court did was to hold up the right of the government to tax something, not necessarily to mandate that someone purchase it, but the right to tax was declared effectively limitless, whether it's a tax on buying something, whether it's a tax on producing income, or whether it's a tax on somebody because they didn't do something, such as not buy health care. So the Supreme Court basically tried to have their cake and eat it too. They didn't really say the mandate was upheld, they simply said the government has a right to tax. There was a second argument that was put forward, and that was that a number of the states argued that the government did not have a right to force them to expand Medicaid. We'll go a little bit more in depth on that, but what the Supreme Court said on that was, correctly, that states were not required to expand Medicaid. But the overview for us, particularly those of us in California, is that California will be moving forward on PPACA, both on the effect on our insurance markets as well as on Medicaid, whether the federal court continues moving forward, whether the politics of the federal Congress and president continue, California is going to move forward no matter what. And so these 4 programs we're doing, these 4 webinars, operate on the assumption that some or all of PPACA will be implemented here in California no matter what. Let's get back to that issue that the Supreme Court deals with, the Commerce Clause. For those of you who may remember your high school history, when our country was founded with 13 original states, it was the right of each of the states to form and regulate their own business, whether it be a bank, a newspaper, or whatever it may be. As a result of it, many states put protective tariffs or taxes against products being brought into their state produced by other states. So for example, if I was a tree manufacturer in Nevada, obviously with California's redwood forest, perhaps there's a tree manufacturer in California that could produce a better chair out of the redwood trees at a cheaper price, ship it into Nevada, and sell it to Nevada citizens. And in order to protect our local business in Nevada that makes chairs, the state of Nevada in the past could have put a $1,000 tax on every chair that comes into California. That would mean, of course, that the California businesses could not operate across state lines. Likewise, California could have reciprocated and said, we have a great wine industry, so we're not going to allow any Nevada wine to come into the state. We're going to put a $1,000 tax on every bottle of wine. Well, you can imagine what a problem that would be if we had 50 states doing 50 different sets of protective tariffs and tax all over the place. And so the Commerce Clause was developed that basically said business between the states is the function of the federal government. That's what's known by as the Commerce Clause. There have been hundreds of laws written around that clause since then. But it basically says any activity that goes between states, any business activities, can fall under the regulation of the federal government. PPACA, however, went one step further. It said that since the Commerce Clause can regulate activity, it can also regulate inactivity. The rationale behind this regulation of inactivity was that health insurance was an intrinsic part of the health industry. We look at our chart here, it sort of envisions healthcare being the blue circle. Since we're not really great artists, imagine the blue circle was a room. Healthcare inside that room would be almost like a fog. And health insurance inside that room would equally be mingled everywhere within there. So even if you try to remove yourself as a citizen from outside of the healthcare industry, part of that fog of health insurance would intrinsically be attached to you. The classic example would be a person not having any health insurance, choosing not to buy any, could be getting into an emergency and going to the hospital, having no money to pay the bill. The hospital, by our law, has to treat the person. He has no money, nothing to seize in a bankruptcy, so who pays his bill? The answer is the rest of us do through higher insurance, health insurance premiums. So that was the basic argument behind PPACA, that they were going to regulate the inactivity of not buying health insurance. Well, what the Supreme Court said was that health insurance is, in fact, a separate and not an intrinsic part of health care. That a person, in theory, could live his life without ever affecting the health insurance industry. So therefore, the Supreme Court effectively said you can't mandate somebody under the Commerce Clause, because the Commerce Clause regulates activity, and not buying something is inactivity. However, the Supreme Court went further than anybody had expected by stating, even though it can't be mandated because of activity or inactivity under the Commerce Clause, the government elected by the people has a right to tax anybody anyway, as long as the duly elected people do the taxing. And therefore, Congress has a right to tax inactivity or to tax people that do not buy health insurance. That's a rather unusual ruling, and we'll have to see what the effect is long term. But you can imagine somewhere down the line in a future Congress them passing a law that says we think people should carry guns, and therefore we're going to tax anybody who doesn't buy a gun. For my liberal friends, maybe a future Congress will say, we think everybody should do 2 weeks of social work without any pay, so we're going to tax anyone who does not have a sign-off that they have done 2 weeks of nonprofit work for somebody without any pay. The idea that we can tax anything, either activity or inactivity, was the new piece. Nonetheless, so while the Supreme Court can simultaneously say you're not mandated to buy it, you are, however, mandated to pay a tax if you don't. That's where that stands for individuals. Well, what about the states? The states won the argument about the Medicaid. Basically, what the states were saying is this. Right now, my state of, say, Texas, just for an example, covers people in what they call Medicaid, and here in California we call it Medi-Cal. And they cover everybody for free if they are within 100% or lower of the federal poverty level. Now, this is not an exact number, but I would just want to give it to you for demonstration purposes. Let's say the federal poverty level was $21,000. That would mean anyone in any of the states having Medicaid could get Medicaid or Medi-Cal if they earn $21,000 or less. PPACA said we are going to raise that number up 33%, or in other words, $7,000 in our hypothetical example. If $21,000 is 100%, 133 would be $28,000. And if it's obviously, if a state raises that federal poverty level, that means more poor people are going to come into Medi-Cal and get free medical care. PPACA offered to pay for those people for the first 3 years and then start reducing the payments to the states, and that's where some of the states started to argue. They basically said, hey, you can't force us to add these additional new people and then 3 years from now start sticking us with the bill. PPACA said, well, we are going to force you. If you don't expand your Medi-Cal up to 133%, we are going to take back all the money we currently give you for the 100% federal poverty level coverage. States called foul and basically said that's blackmailing and you can't do that. You've already promised that money to us. The Supreme Court agreed with the states that the federal court could not refuse to continue paying what they've already promised and that the states do not have to expand. So what happens to a state like Texas that says, I'm not going to expand? Well, they will keep their coverage for Medicaid at 100% of the federal poverty level. That then, of course, will mean that anyone above the 100% federal poverty level could go to that state's exchange and get premium tax credits. Now compare that to another state, such as California, that's going to raise it to 133% of federal poverty level. That would mean employees could not get premium credits until after they've increased the 133%. So a state like Texas, by refusing to expand Medicaid, may actually add more people to its exchange than people like in California, who the people between 100 and 133 will stay in Medi-Cal. It'll be an interesting situation. What's particularly interesting is in states that have a lower federal poverty level for their Medicaid or Medi-Cal, that means the penalties employers pay if a guy goes to the exchange could actually start sooner, because people who go on Medi-Cal do not set off a penalty for an employer. It's only people who go to the exchange and get a premium tax credit where the penalties pay. So in this interesting situation, you could literally have a company in Texas who's paying their employees between 101 and 133% of federal poverty level, decide it wants to move to California because they'd rather have their people covered under Medi-Cal, hence the employer would have no penalties. Well, what about the states that do expand, such as California? We will. We will expand so that all citizens go into Medi-Cal with 133% or less of federal poverty level. But if the federal funding, as currently projected, starts to run out 3 years from now, and if the Congress doesn't add more money to the pool, that means the state of California's state budget will obviously be impacted. That money's going to have to come from somewhere, so it may be more tax increases for the citizens of California, or perhaps cuts in the educational budget, or whatever it may be. It also creates the interesting possibility that two states side by side one of the states may actually become a magnet for poorer, sicker people. I used the example of a company moving from Texas to California. But imagine two states like Kansas and Missouri, where one has the federal poverty level at 133 and one has it at 100%. All you have to do is move across the Mississippi River, and obviously you could be into whichever state will cover more sick people poorer. That may have some interesting ramifications, but we'll see. Have to wait to see how that comes out. California is expected to have 2 million more Medi-Cal members put onto the rolls by 2016. Well, what's in process? What other things are in process for 2012? Well, the essential benefits regulation was supposed to be released by the Health and Human Resources out of the federal government in September of 2011. On December 16th, 2011, HHS decided that was a much more difficult task than they had possibly imagined. So instead of actually releasing the regulations, they simply sent a directive to the state telling the states that they should each define their own essential benefits within a certain parameter or a certain set of rules. Now, if the state refused to do that or chose not to do it, then the federal government was going to look back to the first quarter of 2012, look at the private carriers and the private markets inside of a given state, and choose the essential benefits plan based upon the amount of enrollment in the largest small group plans. We'll get back to that in a moment. The categories of these essential benefits, in other words, the general rules that somebody had to apply, we're going to cover 10 particular things. Let me step back for a moment and explain why this benchmark was essential. First, it was essential to make sure that different states had essentially the same level playing field. Otherwise, you could have companies shopping for those states with the lowest essential benefits to try to cut costs. You could have the sickest people shopping for those states with the best essential benefits. So the PPACA design was to sort of make everything equal across the country. The problem or difficulty in doing that is states like California, who have been highly impacted with managed care programs over the years and whose regulations under the Knox-Keene already had a very robust set of mandated benefits. If you imagined all the California benefits piled up high, you might have, say, 3 feet worth of benefits. But if you turned around and look at a state like Tennessee, very low benefit levels, very low levels of coverage minimally required, their benefits currently might only pile up to 1 foot. So the federal government, in choosing one benchmark, could take all the states like Tennessee and move them up to California's level, but that would, of course, triple or quadruple the costs in terms of state of Tennessee. They could turn around, of course, take California benefits and move them down to Tennessee, or say meet somewhere in the middle, but then the California people who are in government wouldn't like that type of thing, a loss of benefits. So what to do? Well, the answer was kick it to the states and let each of them make their own decision within certain guidelines. It's a balancing act going on in here, because while the guidelines are very broad, as you can see on this next slide, these guidelines are only going to apply to individual and non-grandfather small groups inside and outside the exchange. And they're going to be very broadly based set of benefits. 10 categories are showing up on your screen right now. As you can see, most of them are benefits that we take for granted here in California as part of our most of our managed care products. But because the details of what gets covered inside of these 10 categories was left alone, was left for each state to decide, PPACA is going to fail to have uniform coverages across the country. We will have some states that will have much more robust essential benefits than other states. And that's because the subcategories are going to be defined by the state. Now I want to take a moment here, and I want you to understand these essential benefits are inaccurately described as a plan. When we in the insurance industry think of a plan, we think of definitions of covered benefits and then co-payments, co-insurance, deductibles. In other words, we sort of wrap into the word plan the qualitative descriptors of what's covered and the quantitative descriptors of what's covered. Quantitative would be co-pays, co-insurance, maximum out-of-pocket, deductibles, etc. Qualitative would be how do we define an emergency service, or how do we define newborn care. In PPACA, they take these categories of the qualitative essential benefits that are described and they put them in one bucket, a bucket in your left hand. And then they take the quantitative, co-payments, co-insurance, and deductibles, and they put them into a bucket in your right hand, and they call them metal categories. So you can have an essential set of benefits, but that does not tell you what the deductible will be, what the co-insurance will be, or anything else. That falls into the metal categories. For this discussion on this webinar, we're going to describe what California has done in the qualitative area. And even though we talk about them using specific plan designs from specific carriers, I don't want you to get confused. So for example, if I was to say the California essential benefits for maternity would include at least 2 days worth of maternity care for any mother of a newborn who wished it. That doesn't say, and I described that in terms of a Blue Cross $500 deductible PPO. The description of the maternity benefit for 2 days is the essential benefit. Whether it actually carries the $500 deductible or no deductible doesn't really matter at this point. That's going to be discussed in the metal category. So we have to separate these qualitatives into our left hand and our quantitatives into our right hand. Well, some of the additional requirements based both on the Federal Government Act plus and here in California is along with those 10 sections we just looked at, you're going to have to cover the Mental Health Parity and Addiction Equity Act. That's been around since 2008. All of our plans currently do that anyway. In addition, any mandate that was in place in California before 12/31/2011 will be included in the essential benefits for California, but not necessarily for another state. Question often comes up, can a carrier or an individual put together a series of plans, say a sort of major medical plan that's a very base, and then include riders to cover the essential benefits that are going to be defined? And the answer is no. Essential benefits must be wrapped into one single plan. The state mandates that were not in effect before 12/31/2011, if new mandates come into the exchange at a later date, the state will have to pay for those mandates. So at least that's a good side. You will probably be reluctant to add a whole bunch of new mandates at a later date. PPACA also said that if a state did not select its version of an essential benefits plan by the end of September 2012, that a default plan would go in place based upon those plans in the state with the largest numbers of enrollees. There were 6 states that were close to having their plan selected by the end of September. The only state that actually got it done by the end of September was California. Other states have since joined in, but the vast majority of the states have not been able to accomplish this task yet. And the government decided that the deadline, September 2012, was going to be more of a suggestion rather than a requirement. So we're going to have to wait for the other states to catch up with us. If a state default plan is missing, in other words, if Texas refuses to pick one, as I said, the federal government will come in and will say about those 10 areas of coverage we looked at, we're going to look at the biggest enrollment in your private and public market plans and pick the benefit as described in those largest enrollment plans to cover these essential benefits. So if one plan with the most enrollment, say, has 8 of the 10 essential benefits laid out in it, but is missing 2, then the government would go down and pick the second largest plan with enrollment, look to see if the essential benefits in those 2 missing areas were covered. If one was covered, that would become the essential benefits, and the third one. Now, if you listen very carefully, what becomes the essential benefit is how that plan's contract describes the benefit, not the company plan itself. So every company in California that has an essential benefit plan will not be doing exactly what Blue Cross does or exactly what Kaiser does or exactly what Health Net does, but their language will be consistent with some base set of essential benefits. So how did we go about here in California defining our non-default options? Well, we went about it by calculating the enrollment size, and we sort of did it like a Chinese menu, if you will. Imagine a fold-out of a Chinese menu that's 4 columns. In the first column, column A, we're going to have choices that are being listed from the largest small groups plan, any of the largest small groups plan in any of the 3 largest small group carriers. So we can imagine, for example, C-Change, which is a relatively new carrier for us here in California. It's unlikely to be on that column A in the menu because it's not one of the largest 3 small group carriers. Those of you thinking out loud can probably guess what it's going to be: your Blue Crosses, your Blue Shields, and your Kaiser. Health Net probably isn't large enough to fit into that category. So on column A, let's say Blue Cross ends up being one of the 3 largest small group carriers. Then they will go in and ask Blue Cross which specific plan in Blue Cross had the most enrollees. And the benefits of that plan go into column A. Column B in our menu would be any of the top 3 states' employee health benefit plans. And if you're thinking ahead, you probably can figure out that that's probably going to be CalPERS. Any column C, the third column, is we're going to define any of the 3 largest national federal employee plans. These would be plans covering federal employees who live and work in California. And column 4, column D rather, the largest commercial non-Medicaid, or Medi-Cal as we call it, HMO in the state. Well, rather obviously the largest commercial, not exclusively Medi-Cal in the state, is going to be Kaiser. In fact, if you got your thinking cap on, you can probably see that in column A, there's probably going to be a Kaiser plan. In column B, when we look at CalPERS, there's probably going to be Kaiser in there. Might be Kaiser in the federal plan. Certainly it's going to be Kaiser in column D. Well, who made the benchmark list? A small group, as you can see, Anthem Blue Cross Solution 2500 PPO and Blue Shield Spectrum PPO 1500 value. The Kaiser HMO also made it, and I didn't put the name in there because I'm kind of hoping you're trying to figure it out in your own head which of the Kaiser plans made it. So in column A, we were picking benefits from those plans. In column B, the 3 states CalPERS plans, it was the Blue Cross, the Blue Shield, and the Kaiser again, as we suspected. Column C, federal employee plans, well, it was the Government Employees Health Association plan, which is run out of Washington, D.C. There was also the National Blue Cross Blue Shield Basic Plan. That's a plan that is a national amalgamation of all the Blue Crosses and Blue Shields across the country. And there was also their standard plan. So the language of those plans were put into the 3rd column. And the 4th column, as we suspected, was Kaiser Traditional HMO. And the winner was, as it says, when the governor signed Senate Bill 951, which was also Assembly Bill 1453, the language in the bill said every carrier producing essential benefit plans has to have language in the contract describing that essential benefit qualitatively, and that language has to be compliant with the Kaiser $30 1500. That does not mean every plan and every carrier has to have a $30 deductible or a $1,500 deductible. It simply means that the Kaiser 30-1500, that the bulk of the language of that plan was taken. And forget that it was Kaiser, it was simply put into the law as being a descriptor for the essential benefits. Problem, of course, was the Kaiser 30-1500 didn't cover the essential benefits for pediatric vision. So inconsistent with what we were describing a few slides ago, they went ahead and looked at the next plan with the next largest amount of enrollment that had a pediatric vision, and that was the Federal Health Plan's Pediatric Vision, the Association Plan for Federal Employees. What's really funny is where the pediatric dental came from, because most of us don't have much pediatric dental in the small group and individual plans that we sell. But there is one plan in the state that does, and so they went down and grabbed the language from that, which was Healthy Families Pediatric Dental. So all of the language described on SB 951 that defines essential benefits is picking up 8 of the major categories from a template based on the Kaiser 30-1500, a template based on the Federal Healthcare's Pediatric, and a template based on the Healthy Families Pediatric Dental. Does this mean that a carrier cannot sell a non-essential benefits plan? No. In fact, the bill specifically states in it, with very large descriptors, that if a company is going to sell a non-essential plan, it must, in marketing, very clearly disclose that it's non-essential. This is important because for individuals and companies to avoid penalties after 2014, they have to enroll with a plan that at a minimum covers the essential benefits. So an employer buying a very inexpensive non-essential benefit plan would still be liable for penalties. A family buying a plan that's very inexpensive, not covering essential benefits, would still be liable for the tax penalties at the end of the year. That's why it's so important. So while it would be possible for a carrier to sell a non-essential benefit plan, it's going to be highly debatable whether a carrier would actually want to do that, considering the regulatory fuss they have to keep the plan active here in California, and considering that most people are not going to knowingly buy a plan and still have to pay the penalty. So while it's possible they could have it, it's probably not very likely. Well, where will we have to make adjustments in terms of our small group and individual plans that we currently have here in California? Well, one of the essential benefits describes something as habilitative services. What I'm about to tell you is not an essential benefit, but it would gather the point for you. Habilitative refers to concepts of maintaining function. We don't cover those sorts of things in individual and small group contracts because most of the habilitative work we do on an insured basis in California comes through workers' comp. A person injures his shoulder and he gets recovery and habilitative services until his shoulder is brought back to maintaining functionality and go back to work. That's covered by workers' comp, not in our individual and small group policies. What we cover oftentimes is rehabilitative skills. We have sort of things, somebody, for example, gets an arm injured on an individual policy, and he gets physical therapy until he can restore the functionality of it. But once it's cured the one time, we sort of give it up. Best way to understand habilitative versus rehabilitative would be this. Imagine you were required, this is not accurate, but imagine you were required to cover someone who was hooked on heroin. That individual could be covered on a habilitative program through a methadone. So a state that had that kind of requirement in essential benefits might require an insurance carrier to cover methadone treatments as a habilitative coverage, where rehabilitative would simply refer to detoxing the individual. Sort of the difference in there. Now, obviously, that's a silly example because we don't cover that sort of thing in our state. But it kind of gets the point for you. In California, our act is going to require parity for both sets of benefits. Since our rehabilitative benefits in California are relatively minor in the health insurance side, we don't expect a whole lot of difficulty with this addition of habilitative services. However, the federal government would always have the right to come in and evaluate whether California is doing enough on this essential benefit, so we'll have to see what happens. Pediatric services and dental services, obviously we typically cover a minor thing, such as we might have a benefit for a child to get his vision checked in a small group health plan, but that would be about it. The federal plan probably covers a little bit more. In dental, we cover very little, so obviously there'll be some additions to the policies and additions to cost in those areas. What are some items where we may have some increase for some carriers, but not necessarily all of our carriers? Well, assisted reproductive technology. That would be an area because we do have some differences across our plans. Now, I'm certain the Kaiser 30500 doesn't do in vitro fertilization, so nobody's talking about that. But it's possible that Kaiser may give some guidance and assistance in an area that is not covered in another health plan. So one health plan may have to add it, another health plan may be okay. Hearing aids or surgically implanted devices, different plans cover different things on there, so some carriers may be more effective than others. Acupuncture, some do, some don't. Chiropractic, any services with limitations or of a severe nature, physical, occupational, speech therapy, there may have to be some adjustments and increases in some of the plans in some of the states. Skilled nursing, obviously. And as we've talked about before, anytime the state adds an additional mandate, that's going to have to be paid for through the state. So we probably have some protection in that area that a bunch of mandates won't be added in the future. Well, some of the other things that have changed, and the biggest one is for 2012 is W-2s. We need to listen to this discussion carefully, because what was originally disclosed on PPACA was that employers starting with the earnings earned in 2012, and that would be the W-2s released in January of 2013, that they were supposed to report the economic value of group health plans for every W-2 they released. For those of you who know this, persons quitting in 2012 could ask for an early W-2, so an employer would have had to report the economic value of the health care plan at work earlier than January 2013. Needless to say, this was going to be a huge and difficult task. Just trying to define what is the economic value of group health plans is a task, but to add it on to everybody's W-2, particularly in the middle of the year for early quits or firings, would be enormously difficult. So something had to be done. So a safe harbor was created by an IRS ruling. Basically what the IRS ruling said was that if you had in 2011 fewer than 250 W-2s issued, then you were exempt from the requirement. Any company issuing in 2011 250 W-2s or more still had to follow through providing that information, but they did not have to do it in mid-year. They only had to do it starting January 2013 for earnings in 2012. Now, I want to make sure that everybody's reading that screen and understanding it properly, because too many brokers have been telling their clients it's employers with 250 employees or more. That is not accurate. I could have a very intensive, say for example, a gardening or a landscaping operation in which I have only maybe 30 full-time people. But I could have 300 part-time people during the year, every one of them being issued a W-2, and then I fall into that category. So it's the issuance of 250 or more W-2s in 2011, which mandates that the employer provide the information we're going to talk about in a minute on the W-2s that he's going to release in January of 2013. Now, the exemptions to that, as I said, is Indian tribal government and Indian tribal employers, and those having less than 250 W-2s issued. What goes into this number of economic health value? What's in it? I'm going to give you a very broad brush at this because the Act is very complex. And I'm going to suggest to you that much like when COBRA first came into play, we as insurance people were capable of giving generalized descriptors about how COBRA works and who it applies to and that sorts of things. But it became pretty clear that you had to become really expert at COBRA, and that the best advice an insurance agent could give his client, insurance broker could give his client, was to use an expert for COBRA, like Connexus, something like that. The same thing's going to come into play here. Calculating out this value at first blush seems easy, but as you get into the details, it's not. This is a task that a CPA or someone skilled in this law, in this area, is going to have to do. You're not going to be wanting to fool around with this as an insurance agent. Just merely be able to talk about it in general terms. So what's included? Well, obviously the major medical premium. Now that would be easy. We could easily look, how much did we pay an insurance carrier for this man and his family for the year? By the way, it doesn't matter who paid what on the premium. If it was a 50-50 deal where 50% of it was coming out of payroll and 50% of it coming out of the employer pocket, what goes on the W-2 is the total amount paid to the insurance carrier, no matter who actually gave the money. So major medical is easy to understand. Mini meds, if they're sold through work, that's easy to understand. Ooh. What if you did like you had some type of on-site medical clinic? Perhaps you have a small medical clinic to try to head off some worker comp claims and handle them on-site before they go out. Well, if you had 10,000 employees and your on-site medical clinic cost you $100,000 a year, you could just divide it through and get the number pretty easily. But I doubt if it's going to be that easy. So for larger companies with medical clinics, they're going to have to work with their CPAs to know how much value to put into the number that gets reported on each W-2. Medicare supplements, those, if they run through work, they go on the W-2. Health FSA employer contributions, not the employee contribution, but the employer contributions, they would go into it. An employee assistance program, if there is one in a company, and if that employee assistance program can be offered on a COBRA basis with a COBRA rate to COBRA people, then the value of that is what is calculated and placed on everybody's W-2, not just those who are on COBRA. Here the condition seems to be, how do you go about calculating its worth? Well, if you've calculated it for COBRA, then you can calculate it for everybody. Typical benefits, by the way, there's a lot more involved. I'm just giving the broad brush on this thing. Typical benefits that are questioned that we know are not included. Long-term care provided through work is not. What the law talks about is non-integrated dental and vision. We would call it standalone. So if your dental and vision is included in the major medical premium, it gets included in the report on the W-2. If it's a standalone, then it does not get reported. HSA, regardless of who paid for it, does not get reported. Workers' comp does not get reported. Accident, disability, AD&D policies, they do not get reported. Or some of the more unique things. For example, if a company has a concierge service for its upper executives to help them get appointments, referrals, and that sort of thing, the value of that would not be reported. If you were to go to the IRS.gov site and read the entire section dealing with this number, you would find it very complex and with lots more examples in there. So our advice is get to clients who issued in 2011 250 or more W-2s or came close to doing that, and let them be aware they may need to talk to their CPA or is preparing their tax return. The total on this thing is going to be, as I said, the aggregated cost, how much got paid to the insurance company, not whether it was paid by the individual or by the company. That, by the way, for someone is thinking, this number is being reported. It is not being reported for tax purposes, and that's why it does not matter who paid what. It's, in theory, simply trying to educate the employees about the value and the cost of health care. Fully insured plans are going to use the total premium. Self-funded or partially funded, as a general rule, is going to use the costs that they would calculate if somebody went on COBRA and report that. Obviously, if changes of coverage occur during the year, such as a half-year year on HealthNet, half-year year on Blue Shield, both those changes will have to be accounted for. And if you have a very large company with composite or blended rates, such as Mr. Aetna may go to a very large company and just say, I'm going to charge you $700 a head, whether it's a single, a two-person contract, three-person, or four, then each individual, whether family or single, will get reported a $700 value at that point, whatever it may be. The next thing that started happening, and most of you started hearing about and experiencing this in October, it was a summary of benefits. These were documents that were supposed to be given out at a certain time, under certain conditions, and in a certain way. Many of you have been hearing mixed messages from the carriers as of the recording of this webinar. The carriers are not in conformity as to how they're interpreting the law, and that's pretty understandable. The thing is very complex as to who's supposed to do what and how they're supposed to go about doing it. So our advice on this, we're going to give you the general overview of this over the next few slides, but our basic advice is follow the guideline for the carrier. If carrier A is telling you to do it this way, follow their advice. If carrier B turns around and says do it this other way, follow their advice. Because ultimately the carrier or the employer could be fined in this situation. And it is reasonable for an employer to say, hey, I did what my carrier told me to do. That's a reasonable defense, and reasonable behavior is what's being judged at the moment. We'll probably judge that way for a couple of years before penalties actually get levied. What these benefits and summary documents look like, you can see on the screen there, and I'll leave you time to read it on your own or stop this recording. But basically what it is simply a standardized report. It says we're going to have every carrier describe his plans a specific kind of way, and the law is very specific about how it must be described. It's designed to allow a person to compare across different kinds of carriers. There is a fine that I said good faith behavior is the test that's being used at the moment. No fines are being violated. But once the fines do come into play in a year or two, then you will have to follow certain timeliness that these things always get sent out, just like a COBRA notice. The summary benefits coverage has to include a 4-page benefit summary, and it's going to be a front and back item, so it's going to be about 8 pages. It has to include medical scenarios. In other words, what happens to me if I go in for a doctor's appointment? What happens to me if I get pregnant? That kind of thing. It has to include a glossary of terms, and it obviously must include customer service and website information from the carrier. Here's another example, and you can see it talks about important questions. What is a deductible? What's an out-of-pocket? And obviously this is adjusted for each of the different plans the carrier may sell. When we talk about these scenarios, as you can see, there's 2 types shown on your screen right now. 1 is having a baby, and 2 is managing type 2 diabetes. Now here's where a lot of misunderstanding occurs. An employer is not free to just decide what type of medical scenario to use. The medical scenarios mandated in the Act, and 2 of them you see on the screen here, and the rest are available at the IRS.gov site. It is those scenarios that must be analyzed, and that gets to be rather difficult. The IRS requirement for all this is that there be 4 pages of double-sided, so 8 pages in total, 12-point font. Can't be 11, can't be 13. Must be linguistically appropriate. You can imagine how difficult a task that would be in a state like California, which is why if the carrier's deciding that linguistically appropriate is 8 different languages or 12 different languages, then follow the carrier's advice. The summary plan description does not substitute for a summary plan description does not substitute for the SPC. You can hand both of them out separately if that's what you wish to do, but the SPC must be handed out regardless of what you do with the summary plan description. The IRS templates are very specific. Go to irs.gov to check them out. And there was some confusion. Originally, premium had to be included in these SPCs. That is not true at this time. You do not have to add premium. Everyone is required to hand these things out, whether you're fully insured, partially insured, or self-insured. Large groups, small groups, individuals. Grandfathering does not matter. Everyone has to hand them out. What is excluded is standalone dental, vision, FSA, HSA, or specific disease-type plans. Fully insured carriers are required to provide the SPC. So if you're dealing with your traditional small group or individual, Blue Cross Blue Shield, Health Net, United Healthcare, Kaiser, etc., they are the ones responsible for creating the documents. They're the ones responsible for getting it to the employer. The employer has to hand it out. But that obligation stops on self-funded plans, rather obviously, because so many differences could be in self-funded plan depending on how it's designed. So the burden on self-funded plan is completely on the employer. He has to both do the production of the piece as well as actually hand the thing out. Our suggestion, obviously, is that when he contracts with an administrator for his administration of his self-funded plans, that he contracts for that service as well. Now, the whole activity of handing these things out was supposed to start on September 23rd, 2012. Which obviously meant the first possible annual enrollment date for it would have been October 1st. And as many of you know, that date was missed by the vast majority of our people, simply because the regulations weren't out clearly and far enough in advance to do it. But from this point forward, when you do an annual enrollment or when you have a new effective date for a non-annual enrollment, the SPC has to be handed out. When a person, a new hire, for example, applies for coverage, they must be given an SPC. If an enrollees are automatically moved to a new plan design, let's say mid-year for whatever reason, a particular set of benefits is dropped and everybody's moved into possible new choices, SPCs have to be handed out at that point. Anytime you get special enrollment situations, such as perhaps a person brings their spouse back onto the plan, they were a qualified late enrollee because they were covered by their spouse's employer-sponsored plan. That spouse loses their job, and so the employee and that spouse come back onto the original employer's plan. They would have to have an SPC handed out at that point. And anytime a person on the plan, a participant or the beneficiary, requests an SPC, the employer has to hand it out within 7 business days. Obviously, anytime you do mid-year off renewal, in other words, major modifications, then you have to give a 60-day notification, and the SPCs go out then too. What's the next step? Something that we expect to hear more of after the 1st of January 2013. Hopefully we'll be out doing some training on that with everyone. PPACA, when it was passed, envisioned something called a highly compensated employee, HCE, testing. And that testing was supposed to begin in 2011. However, days before 2011, on December 22nd, 2010, the IRS came out and told everybody, forget it, we don't know how to do this. This is a very complicated task to accomplish, and the regs weren't ready yet. So they spent all of 2011 trying to figure out what to do, came out with some suggestions in the spring of 2012, but when those tests were done by some of the accounting firms to see how many companies might fail a highly compensated employee testing program, about 80 to 85% of all small groups would have failed. Obviously, with the elections coming up, within 6 months, the IRS decided to hold back those regulations. They've been working on them ever since, and we expect them to come out any time. But what can we tell you about HCEs? Well, number one, of course, grandfather plans are exempt, but only until 2014. After that, they come into the play as well, which is why everybody was trying to keep their plans grandfathered, but as we know, that was impossible here in California for small groups. Highly compensated employees say if a person is discriminated against, then the penalty of the employer is going to be $100 per day per person discriminated against. So imagine you have a medical clinic, 5 doctors own it, and they have their health care and their family's health care paid for 100% by the clinic. And the plan they're on is a zero deductible, statewide top-grade PPO network. And everybody else, other than those 5 doctors who are the owners, are placed on the lowest level Kaiser HMO and are required to pay 30% of the plan out of their payroll. Well, you and I can both agree that's going to be discriminatory. The problem is going to be is when you have plans that are very close to each other but not identical. Will the testing show those to be discriminatory, such as the 5 doctors are on a $1,000 deductible PPO, 80/20, $2,500 out of pocket, for which they are paying 60% of the premium, and everybody in the shop is on a mid-range HMO fully paid for by the employer. Is that going to be declared discriminatory? We don't know. It sort of goes back to that old phrase that came out of a Supreme Court decision. One of the Supreme Court justices was asked to decide if a particular thing was pornographic when we were having all the fights about pornography. And the Supreme Court justice wrote in the opinion that while he could not define pornography, he knew it when he saw it. Well, it's sort of like that for us in our small group cases. We know there are small group employers out there who are clearly discriminating without question, and we're going to have to get them into conformance by 2014. Hopefully we'll have the regulations after 1/1/2013 to be able to define how to do that. Up until then, we've got delay and delay until after the election. However, logic suggests kind of what the regulations may look like. The logic would simply be, say you were testing for discriminatory behavior in a 401k plan. You were testing on discriminatory behavior with certain employees having better benefits in the life insurance area and having those benefits taxed as a result of it. We suspect it's going to be something along those lines. The last big major item that we wanted to cover that was updated was something that was stymieing a lot of employers. In the last of our seminars, our 4 seminars in this sequence, we're going to be talking about an employer paying penalties if he does not offer the right kind of coverage to an employee. And we're going to use a chart that you see up on the screen right now. On the 3rd row down, the PPACA talks about an employee who is going to be means tested by the government to see whether he qualifies for certain kinds of tax advantage premium credits. And if he fits that definition, he's going to get help from the government, and subsequently the employer was going to be fined. But in order for an employer to avoid that fine, he would have had to know, as you can see there, whether what he was charging his employees was 9.5% or more of their household income. In other words, he's offering them a policy which deducts $100 a month out of his pay. That's $1,200 a year. Well, how would an employer know if $1,200 was 9.5% of a guy's household income? He would know what he paid him, but he doesn't even have a way to check the household income. So obviously this part of the act was significantly unfair. So what they've done then is to create an IRS Safe Haven to change that. The rule will be, starting in 2014, that an employer will not be able to charge more than 9.5% of the employee's income earned at that employer. He will not be able to charge that unless he wants to risk a penalty. It's not going to say that an employer can't charge more than that. It's simply going to say that if he does, he could be facing a penalty if the employee went to the exchange and got his premium tax credit instead. So no longer will we have to worry about knowing a person's household income. We will be able to help the employer at this point because obviously the employer knows how much each person is making. We can help the employer do the 9.5% test because we're going to know how much he's charging as part of payroll contributions. So what have we got? The most essential benefits and changes that have occurred in 2012 was the essential benefits was defined here in California. The fact that W-2s issued in January of 2013 need to carry the value of the health care provided by the employer, but that's only for companies that issued 250 or more W-2s in 2011. We know we are starting to issue summary of benefits and coverage, and our guidance is to follow the rules of the carrier you're working with, even if those rules may be different. And I guess the other, sort of like the question of compliance, what do you hand out for a COBRA? If in doubt, hand it out would be sort of a safe rule. So if in doubt, hand out the SBCs that the carriers provide you. We're awaiting more information for the highly compensated testing rules, and we will get those to you as soon as we know them. We'll come up with some training classes for you, hopefully after the 1st of 2013. And the affordability safe harbor rule, keep in mind that that's now changed to 9.5% of what the man is paid by his own employer. The next webinar we're going to be doing is going to be talking about the latest developments on exchanges, particularly those developments here in California. Thanks for listening, and we'll get back to you with our next webinar in a few moments.